Order.
All right, James, the floor is yours.
All right, I'll start with sharing my screen, which is just a picture of you guys now. All right, here we go. All right, well, my name is James Flynn. I've gotten to go all over the country working with 70-something tribes, all of it dealing with electronic health records, care system design, like care teams, designing those care teams, tweaking the EHR to kind of work for us as a tool in our benefit, rather against us in a lot of ways, but also just general improvement, from the way patients walk into the building to the way they walk out, what their experience is. And I want to talk about a couple of things today. I'm going to basically, if anything that I say here, you're kind of fuzzy on, we can ask questions at the end of it, and I can totally one-off with you, and we can do a Zoom next week or something. And I can totally show you what I'm talking about. But I do this, I love it. I'm very passionate about it. So I have no problem answering any question to anyone off the cuff. All right, so I'll go ahead and start. I'm gonna open up my slide deck so we can kind of go through it. So I'm gonna do a basic walkthrough first on the slide deck, and then I'll kind of do a live view. Hopefully Brian might get it up and running by then. And if not, we'll log into another place where I know it works. So, all right, so can everyone see my screen? All right, perfect. All right, so this is where I'm from. So this is rural healthcare to acute. This is Kodiak Island, Alaska. And this is kind of how I started my journey 20 years ago in Indian health, kind of learning how do we deliver care in these very remote places that you can only get to by seaplane or, by Coast Guard boat or something like that. So these guys were one of the first people in the nation to meet all of their GIPR measures. And soon afterwards, people are like, well, how the heck did these bumpkins out in the middle of nowhere figure out how to do all this stuff? Well, we basically worked the people around the system, and we worked our EHR to kind of meet these measures. So I'm going to talk a little bit about that today. So here you get to see some of my journeys around the country working with different tribes. You see that, all the way from far north, all the way to Florida, all the way to Maine, all the way to the tips of Alaska. I've gotten to work in different healthcare systems. So I've kind of learned what works, what doesn't work, the common obstacles that we all face, how to quickly move something forward. And so I've had a lot of fun working with different tribes, and I'm in San Carlos right now, Apache. We're doing the same thing. We're on a 4-year journey to improving patient care. So to understand, this is basically the Indian care model right here. And what a lot of people, when they come into our system, don't understand is we're not like a private practice. And it kind of always irks me a little bit and kind of cringeworthy when people say stuff like, well, in the real world, this is a totally different beast. This is the real world, by the way. We're not, subpar humans here or anything like that. So what I like to do is no, this is the Indian health model, and this is how we provide care, and this is how we look at it's holistic care. So it's not just treat and street and get the person on the thing. We have to manage chronic diseases. We are really charged with a lot more than your average healthcare provider. So when we look at this whole entire thing, one of the biggest things, what color on here stands out to you? Just anyone can say anything. You guys can jump right in if you want. So what color stands out? All right. Well, the correct answer is red. So effective relationships, right? But if you look at what we're really trying to do at the end of the day, you know how in real estate they say location, location, location. It's relationship, relationship, relationship. Right now here at San Carlos, we are now getting patient satisfaction coming back, and they're basically saying, hey, I love the care team, my care team this, my care team that. They now understand that this is their primary care provider and this is their care team, and they are really moving forward with their healthcare. So before we get into that, we'll get into that at the end, but we're going to start showing the electronic health record and how we can manipulate it to work better for us. So this is the Institute of Healthcare Improvement's triple aim. So whenever I look at anything, I'm always trying to improve the quality improvement of the population, the quality measures of the population health. So that would be your GIPR measures. We're running simultaneously, what do the patients think, satisfaction scores, and then we're always trying to increase workload and reduce waste. So that's the triple aim, and that's what we're going to talk about today and how we do that. So this is one of the more important slides I have, and it's basically talks about here's how your phases of improvement. And a lot of people think it's the EHR. Well, the EHR is just one little tiny thing in here, clinical information systems, but you have to empanel your patients. You have to have a care team set up. You have to have behavioral health integration. You have all these other things like aligning with your strategic mission. It's a process, shall we say. And these processes, sometimes I go 4 or 5 years working with just one tribe to get them to the finish line of what this looks like. And it's monthly. So I will go there for like 1 week, a month to get there. So you're not going to learn it all. There's no easy button in this one day. This is basically an introduction to some of this stuff. So here are the 5 main things we need just in order to not get yelled at by the coders, right? So here it is, the 5 things needed in order to build. So you need a person. So that's the patient. You need a location. That's like what clinic you're in and, you know, what time is it, you know, and is it ambulatory or is it a chart review or is it telehealth? You need a purpose of visit. Why are they here? Or you could call that a diagnosis. We need a note. And then we need an evaluation and management time, or what we call an activity time. So if you're in behavioral health, you might call it activity time. But the E&M is like basically how difficult was this visit? Was it a 99213, a 99214, et cetera? So you guys probably already know all this. But if you have seen one of those things, it will probably come back to you. So first thing that we can do in EHR is we can come in here, and this is my demo database, so you don't have to worry about anything. What we can do is we can come into here and we can set this up to run off of our clinics, right? So what this will do is take care of number 1 and number 2 right off the bat for you. So it'll take care of the person and it'll take care of the yellow box of location. So we set it up to clinics, and what will happen is the people who are scheduled today will show up at the top here. And when you click them, you already have number 1 and number 2 taken care of. So I hope all y'all set up at, you guys have that set up at clinics. So then when you come into the visit, so this is what we would call a panel EHR. So what we're going to do is we're going to talk about the things in here that we can do, kind of like this is, we'll start with the manual and then we'll move to the more slick way of doing it. And then hopefully we'll do a live demo. So I'll try to be quick. So the first thing you're going to do, this is normally like an MA. So an MA will come in and start rooming the patient, and they'll go through basically the basics that we do almost every visit. So they'll kind of go over height, weight, vitals, so the basic vitals. And a lot of people now incorporate, they look at the health screens as vitals. So it's just your everyday, you room it, it's a vital now. So they do alcohol, tobacco, depression, domestic violence. A lot of other sites will also do activity screening and then maybe ask for anything else. So this is becoming normal for like an MA rooming a patient. And sometimes I go places, they still have nurses doing this. We really want to look at our care teams, and we'll talk a little bit later about that. So here I'm coming in, I've added a new health factor. And here you can see some of the ones I can choose from. I can do an alcohol screen, I can do a diabetic eye exam, diabetic foot exam, fall risk assessment. All right, and then once you get in there, let's say we're doing the alcohol screen, I would go in and say whether it's normal or negative. If you notice on the right-hand side, you can also enter historicals. So let's say we went to like the casino, or we went someplace else, or we had like we went to a gymnasium for a health fair and we did a whole bunch of these. We can come back and actually enter them historically and get credit. And you'll see a lot at the end of when the end of the GIPR year gets closer to, we start getting in September, people are going in and trying to find historicals and enter them so they can meet these measures. All right. So next, we coming down on the left-hand side, so we would be triaging the patient. We would be doing, so we do all the vitals. We would do the health exams. Now we're doing some patient education. So there's 2 educations that you always need a secondary action on. Does anyone know what those are? I know you're all muted. I don't even know why I'm asking these questions. So so basically, if you have a positive alcohol screen, you have to do a brief intervention education. And if you have a tobacco user, you have to do a tobacco quit. So the first thing that I'm showing you right here is what we call, let me move my little camera stuff out of the way. These are called pick lists. So this is something that you're going to want to create, especially if you're like a dietitian or nutritionist or something like that, or you do prenatal stuff. So you're basically first trimester, second trimester, third trimester educations. What you want to do is you create a pick list under the educations and then put them all in there. So here, in the background, you see there's it's depression. So they have multiple depression educations. So what this allows you to do is quickly click on like 6 or 7 of these and just hit OK, and it boom, does it all at once rather than going in and out, in and out. So I'll show you kind of what that way looks like. So this would be under category list. So, oh, sorry, this is before that. So here we are. You can make a GIPR pick list. So you can put these important educations in a place that you can quickly grab them, and you will get that credit. So every time you have a tobacco user, you go boom, you hit tobacco quit. Every time you have a positive alcohol screen, and by the way, positive is just like, yeah, I have like a beer. It's like a cage 1 now. So what we do is we come in and we inform the patient that A, they're positive, and then that B, we have stuff available if they want it. So we have brochures, we have chemical dependency, behavioral health, all these things. And so that's enough to get the brief intervention education. So what you're going to want to do is start to think about, yeah, what educations do I want in my job? What educations am I constantly doing over and over again? And why don't I just make my own little pick list? And that way I can just grab them real quick. So there you go. And then here's the category list of educations. So here I just went into mental health because I think this whole thing's sponsored by like, SAMHSA or something like that. So I want to make sure we have a behavioral health twist on all this stuff. So yeah, so this is just, you would basically go under, so it's not clicked off on pick list anymore, but it's clicked off on category list. And this is normally how your educations will present itself when you open it up. So you would just go down and you would pick mental health or whatever and pick out whatever it is in there, and you get that education credit for you. All right, so moving down. This is the third thing that you need on a visit, purpose of visit, right? So what I like to do is, again, the behavioral health twist here, we created a pick list and we put all the common behavioral health ones in that pick list. So again, if you're like, you see there's a COVID-19, so we built all those when COVID came out. That was lots of fun, real busy doing that. We can do it for diabetes. We can do it for blood pressure. We could do it for, the podiatrist. When the podiatrist comes in, he can have his own little foot one. What this is quick, easy to grab stuff for you folks. So you can also ask somebody like Brian or somebody else to run a list of, hey, what are the most common purpose of visits I do? Could you make me my own pick list that I just have my top 10? I've gone to places, I think we were up in Maine and they had, Billboard 100, like the top 100 things that they did or top greatest hits or whatever. So we can create these pick lists and that could speed up our visits and make them more efficient. All right. This one is kind of the mother of it all. So this is the screening dialogues, and these are what we call quick notes. So if you look up in the top right-hand corner, you'll see there looks like a little Excel spreadsheet with like a pencil on it. So in there, what we'll do is we'll create what we call a quick note, and it will automatically tie in with a template and automatically tie in with a note title for us. So we just do one click and it boom, pops up a template. And I'll kind of show you what that looks like. So right now, what we're looking at is a quick note, and it's going to be the IFHC screening bundle. So this is going to take all of those things that you can do one by one, like the exam, the tobacco, the alcohol, the depression, domestic violence, and it's going to put it all in one place, easy to grab, and you'll get the GIPR credit for it. So I'm going to kind of show you what it looks like. So here it is. I created a visit, did all that stuff. We already got the IPL, so we have 4 of the things. We're on the note now, right? So we have 4 of the main things for building, and then this pops up, and this is a screening bundle. Now, I don't know, maybe in the chat or whatever, but I hope you guys have a screening bundle on your EHR. I hope you have this as a quick note, and if not, I can show you, or Brian can show you how to get these going and operational. So this is a pretty basic screening bundle. So if you look at it, I've opened it up and I started the tobacco use screening. and then I'm starting the tobacco use assessment. But if you look right below that, we have an activity screen, an alcohol screen, a depression screen, an intimate partner violence screen, and a colon cancer, like they're looking for history, and then a history of mammo. So one-stop shopping. So if I'm an MA and I'm rooming the patient and I go through all of the vitals first, I can quickly do these screens. So a lot of people will have them on like a piece of paper where they give it to the patient and the patient will fill it out. And this is where the MA will quickly input all this information. Sometimes you can just ask the questions in the room while you're rooming the patient. Do you drink? Do you smoke? Do you feel safe in your home? And I know I'm at a place that really is doing this repetitively when I watch them room a patient, and the patient will literally say, like, as they're walking in the room, they're like, I don't drink, I don't smoke, I feel safe. Like, you can tell that that patient's been asked that question a lot because they're already answered it before they get into the room. So the benefit of how these work, these dialogues, is not only are they going to put that into the note that you've done it, it's going to push that information outward into the places where we need to get the credit. So it's going to push it back to that health history tab or that wellness tab. It's going to push the education back. It's going to push the exam back. It's going to push the results back, and we'll get those GIPR credits. So the people that we see with the people that we see who really turn around and meet all of their GIPR measures basically develop a care team, and they say, you do this, you do this, you do this. So they stop those patients from falling through the cracks, and then they utilize these tools to the max. So what they're doing is they're coming back to me and they're like, James, can you put an HIV on here? James, can you put a, maybe we have a syphilis outbreak. Can you put a syphilis test on here? And I try to create this one-stop shopping bundle for them. We have ones down here where there's a whole bunch of things for the providers to do on the same screening bundle. All right, let's see if I can advance this. All right, next, this is a behavioral health pick list. So what we did at this site is basically, these were the top codes that behavioral health was using. So a lot of these are like time codes. You probably are familiar with these HCPCS codes, like alcohol or other drug treatment program, 15-minute session, 45-minute session, 30-minute session, psychotherapy. We can create pick lists that will correctly and quickly address that last thing, right? That time factor, how, we call it E&M or we call it activity time. But we can create these pick lists that you do over and over again, and we can load them for you so you can quickly grab them. So we have education pick lists, we have CPT pick lists, and we have ICD-10 pick lists. So these can speed up your stuff, and or we can load them into dialogues like you just saw. All right, so, or we can do it the old-fashioned way where we go into a simple template. Now, the problem with the template is templates can take information into your note, but they can't push information out. And that's kind of what the difference between a template and that dialogue, we call it a dialogue, is that screening bundle dialogue. That screening bundle dialogue pushes information out. And that's where we get the credits. We do not get the credits, however, when we put it in a note like this. But still, we can build these notes that are more effective and better for you if you'd like. So here's an example of, this is during COVID. So we went in and we created a telephonic and telehealth. And by the way, you can bill out for all that stuff. And I know all the codes for it. So if you ever want to know how to bill out for telehealth or set up telehealth, I can help you. So that's what these guys did. They set up, they said, oh, wow, we aren't just seeing people face to face anymore. We need to change the way we do this. So they've created templates that can better ease that. And that helps the coders and the billers and the back end. So they see, oh, this is they went to the house or they did a telephone call or telehealth. All right. And then here's what it kind of looks like when you get them. Here, I got to move my little cameras here, apparently. Here's what it looks like when you put everything into like folders. So you want to develop these templates. So we have the behavioral health follow-up, the evaluation, all the things that you kind of do over and over again. You're going to want to make sure that these templates are designed, and we can make these no problem and kind of give them back to you guys. All right. Kind of like lastly, but not leastly, reminders. So reminders are dialogue. So that means when you do your clinical reminders, they will push the information out and you'll get those GIPR credits. The greatest part about the clinical reminders is they're chart reviewing for you. We call this like clinical decision support. But really what it is it's chart reviewing you and it's saying, hey, hello, this is a diabetic patient and I can't find a diabetic foot exam. Hello, a diabetic patient can't find an A1C or an eye exam. Also, this patient has never had an HIV annotated, and we're probably going to need to do a lipid profile. So if you just do the red clock, and the way you do that, a lot of people don't know, they click on that red clock at the top and they're like, well, I can't do anything. Well, you have to start a note. And when you start your note, if you look down, you know, kind of where it says new note, right below that will be reminders and you can click on it and you can do them. And if you click on them, so if I clicked on diabetic foot exam, for example, it will pull up a dialogue and just do what it says, and it will push that information out and resolve it for you. So again, that red clock is telling us what we need to do. It's telling you like, hey, we don't need to really do the alcohol screen or the depression. We already got that. This is what we need to do. So if we just train people to look at the red clock, observe it, and follow through with it, we will meet all of our GIPR measures. All right, and finally, last but not least, and I'm bringing this up because kind of like I got it. We're talking about behavioral health. We got to talk about the suicide tab. And I've gone to a number of places now where I haven't seen this on the EHR, and I was wondering why. And a lot of them were, they weren't on the EHR because they were taking part of like a health information exchange, and they were having a problem with CFR 42 ruling and public health information and stuff like that. But by the way, this is mandatory reporting. And this actually, when you fill this out, it does report to the state, right? So because this is funded by like behavioral health, we're going to want to make sure that everyone knows that there's actually a suicide reporting form built into our electronic health record. And even if it's just ideation, we can fill this out. So I just wanted to just cover that briefly before we get into some of the fun stuff. All right. So now we kind of know a little bit about the EHR. We know that we can click here and click there, and we can create these cool pick lists, and we create these 2 templates, and we can do this. But really, at the end of the day, everything comes down to roles and responsibilities. You have to look at everything in that big healthcare model that we're supposed to be doing, right? You know, whether it's referrals, follow up on referrals, consults, follow up on consults. Oh, this person had a PAP, this person had a mammo. I'm going to need to go into eye care and look at CMET and find out what these findings are. We're going to need to track these people because they've had a positive finding, and we don't need to wait 10 years. We need to get them back in 5 years. How do we do that? All this workload that we're charged with, because again, we're not an urgent care clinic. We are charged with holistic care. We're primary care providers. So we're supposed to be managing all aspects of these multiple comorbidities of these patients. So that's a hard thing for people who are from outside Indian Health, don't kind of understand that we're a patient-centered medical home model. Therefore, we need to be providing all this care. Luckily, our places, like when you go to Porch and you go to these other places, they're pretty set up. Like you walk in, and this is what separates us from other healthcare systems, is you go in and they got optometry, they have x-ray, they got lab, they have behavioral health, they have, you know, you name it, they got it. And this is so awesome as a patient. And this is why we deliver some of the best healthcare, believe it or not, even though we get down on it all the time, is I want my kids to go to a place like this. I fight for it every time because I know A, they're going to take care of them, and B, it's holistic. I'm not getting like 45 different bills from every single entity inside the hospital. The pharmacy is ran by the tribe. The lab is ran by the tribe. The optician is ran by the tribe. The radiology is ran by, it's all one system. And that's what makes our package lovely. So this is South Central Foundation. So this is up in Alaska where I'm from. And this is the original kind of care team that we set up. So if you take a look at this, this is like, you know, some people kind of dream of this kind of stuff, right? These guys, by the way, win awards and excellence all the time. They have like Aldridge Awards. They've won it all, right? So here it is. They have a physician lead, primary care provider. they have an RN case manager. So this person is really like, you'd think of one person being the coach. This is like the quarterback. That RN case manager is like the champion of the whole team, the glue that holds the whole thing together. That case manager actually has support. So that person has an assistant. That's how beefed up these teams are, right? So that case manager support person, she's basically following up on phone calls, doing a lot of that, where did that referral go? Did that appointment get set? Stuff like that. So you got the provider who's seeing the patients. You got the RN case manager who's basically quarterbacking this whole entire team. Now you have a case manager support who's following up on the patients outside of the doors, outside of the clinic, right? You have a dietitian built in. You have a mid-level. So what the mid-level is really doing for this provider is that mid-level is basically taking care of a lot of like, hey, this patient isn't coming in for something very complex, or this patient is just coming back for a follow-up from an ED visit. They're hitting that mid-level. So rather than using your most valuable resources, they have it devised up. They have an MA, so the MA is the one rooming. They actually have that dietitian, as you see. But here's the game changer. They have inserted behavioral health consultants into the mix. So if you get a positive, if you're a provider and you walk into a room and you got a positive depression screen, you can't just be like, oh, well, I'll just annotate that and see you later. You got to interact. And that's going to take up a huge chunk of your time, and you might have more patients stacked up behind. But that's where we can go in and we can actually get a subject matter expert to kind of do a warm handoff and say, here, let's go down here and let's go to this room, this talking room. And then they hand off, and that's where we see a lot of success in getting these people into the correct programs and preventing suicides and stuff like that. So this, I want you guys to start to think that the easiest thing to really create the largest leverage spot is not only your electronic health record with that, but the design of a care team. So start thinking about all the work that needs to be done and how do we define these roles and responsibilities and who does what. So, and I'll give you some examples of these roles, right? So at one of the places I'm working, San Carlos right now, for example, they have an RN/case manager, and then they have a care coordinator on these teams. So they are designed there. And by the way, you can configure these. I have like 8 slide decks on my desktop right now, and they're all different care team configurations that I've seen all around the country. So what they have is something very unique. They have a care coordinator. So they manage eye care panels, schedule patients for appointments at the clinic. They follow up on referrals, and they get the documentation into the EHR. Their RN case manager, who's right there on the team, right next to that person, they're doing chart reviews for today's patients. They're looking at the clinical reminders. They're basically triaging, wound care, stuff like that. They're doing all the things that the patient is now present. So you have this care coordinator who is managing kind of outside the building, and then you have the RN who is managing today's stack. So I'll kind of give you an idea of what some of these care teams look like. So this is from a place down here in Arizona, and they have two sides of their building. They have a gold side and they have a purple side, right? Or lavender is, I think, what they call it. And each one of those has 2 teams. So you have 2 teams right here. And this is kind of how they devised to work up between the 2 teams. And let me see if I got to kind of move my camera around here to the side or something. All right, so here it goes. So they have 2 physicians, and they have like rows of op rooms. So one team's on this side, one team's on this side. So they have 2 physicians led. They have a care coordinator. Again, that care coordinator is managing the care outside, making sure these patients get into the clinics and managing that. They have that RN case manager. That case manager is managing all the patients that are there today and what they're due for and what blind spots, like meaning that, this patient might be coming in for, hey, I have a cough for 3 days, but they're seeing and they're catching that, dude, this person hasn't had an A1C in like 2 years. And they also had a colonoscopy recently. Where are the results of that? They're doing that. They have a BH consultant, a part of that care team that's floating between the 2. And then they have about 4 MAs rooming patients and, doing all the health screens and all that stuff and the health history, and sometimes like the medication reconciliation, stuff like that. But thirdly, they moved PRC. So as you come down the hallway, as you're leaving, you have literally a scheduler and a PRC clerk there. So they are not only scheduling the next appointment for that patient, they're also pre-authorizing purchase and referred care right there on the spot, and then scheduling that outside appointment. This is a huge game changer compared to like other places that I've been where they aren't doing this, and it takes you a week or two to review, where you got to go in, you got to get, oh, is this person, what level they are for a PRC, level 1, level 2, level 3. This person's right there. They're a subject matter expert, and they're doing it right there on the spot. So to get there. So let's say you just wanted to, this is what I call a driver map. And so this is good for any organization to use for any task that you want to do. So these guys wanted to create a patient-centered medical home model because they were going for Joint Commission, patient-centered medical home recognition. So they had to create a care team. So we just broke it down. We're like, okay, if we want to do this by 2022, what do we got to do? And this was to increase our GIPR measures and our HRSA UDS measures. So we basically wrote out a list. So we have our aim. We wrote out a list of who's doing what. So we have clinical informations, policies and procedures, education, the community, and educating and training the team. And then how do we configure that care team? And then on the right-hand side, we put, these are the actions that need to happen in order for us to get there. So we do need to create policies. We do need to create procedures. We do need to do trainings and how to set this stuff all up and how to use the EHR. And then, last but not least, we need to define our roles and responsibilities. And I can share what a case manager job description, what an MA job description, all these look like for you guys if you want. How am I doing on time, by the way? Am I all right?
Yeah, you're good. You got till 1:30.
Got till 1:30. Oh, geez. I better slow down then. All right.
Well, we don't have to go that long. But
All right, awesome. All right. You guys will probably get sick of hearing me anyways. So like I said, this is not, there's no easy button in healthcare, and you guys all know this. You've been in it. It's a constant. We're never done improving. We're never done changing. We're constantly changing. We're constantly iterating and evolving and adapting to whatever is getting thrown our ways, like COVID. But I want you to know that if you muscle through it and you just keep, it's a mindset. If you just keep saying, we can do this, we can do this, we can get better, you will incrementally over the years improve your whole entire healthcare system and the health of the people of your population. So here we are pre-COVID. This is San Carlos. And what they did is they said, we want you to come down for 1 week every single month for 4 years. And we just want to go forward. So these guys were meeting like 3 or 4 of their GIPR measures. They were not very good. They wanted to become Joint Commission certified patient-centered medical home model. So they basically said, we're going for this. Now let's build it. We've already committed to it. So let's build it. So here I am. I'm coming down and I'm doing training session after training session. This is on a Saturday. And I want you to look at the back of the room. So in the back of the room is your chief nursing officer, your CEO, and your outpatient director. So this is a Saturday. This is the commitment that they had. They're bringing people in on weekends, and we're doing like 4-hour training sessions. Now, of course, they're getting paid overtime, and of course, we have to, get cool swag, and that's why they all have sunglasses on, and we got them treats and all that good stuff. Yeah, and you can't do anything in Indian country without having food, so you got to bring food in. So, long story short, they had fun, we had fun, they learned, and their system improved. Here's them training. So here's a funny thing too, because if you look at where we were 8 years ago, if you looked at where we were 5 years ago, this was a healthcare system that was kind of like IHS operated, and then they became a 638, and their mission statement, right, bold as can be, first sentence was Apache healing Apache. So now you look at these new waves of nurses coming through their programs, what are you seeing? There's people taking care of their own people, and it's absolutely a beautiful thing. And oh, by the way, they know everybody. They're related to half the people. So they know how they have that relationship. If you remember that first thing that we said, the most important thing we can have is relationships. They know that, Elmore is not going to take his meds. They know that so-and-so doesn't want to go to they also know that so-and-so will make so-and-so go to get their colonoscopy. They also know. So this relationship is now leveraged forward and to their advantage because they're going to put the extra time and the extra care. They also know that, hey, if I can't get a hold of them at this number, I'll just call Betsy over here and she'll go run over to the house and get them. So this works to our advantage. Here's another training with, this is basically oncology, cardiology. And so this is train the trainer. So this is more their specialty clinic. And these are the lead RNs of that specialty clinic. So they run it. And so not only are we're training them to train everyone else. So I'm training them kind of be like to create the pick list and how to train people to use eye care and how to use clinical reminders and build clinical reminders. So now they're becoming self-sufficient. So they don't need me kind of thing, right? So there I am working with these guys. They're getting trained and now they're going to go out and show everyone else. And I'll give you an example what that looks like. Here it is. So the lady on the right, Marla Stevens, she's quality improvement. We've trained them on eye care. And the lady on the closest to you in the bottom left is Marlene. They were trained to train people in eye care, and now they're training everybody in eye care. So they're training the rest of it. So now we're talking about scalability. So much in Indian country, and you guys all know this, people have knowledge and they don't share it. They're like very weird. They're like, oh, I can't give you that key. You don't have the responsibility to have this key, and you can't, and what we really want to do is reverse that. We want to expand knowledge and show everybody everything so we can actually have a robust healthcare system. So we want to train the trainers. We want to show people how to use these tools where they can quickly look up every single person who needs an HIV test, where they can quickly look up every person who is due for an A1C or has a high A1C, or everybody who's had a positive Hep C, something like that, right? So expand and spread knowledge. Here is a demonstration of what we call a nurse huddle. So that's Christina in the middle. She's got her nurses all gathered around. This is a great example of an open floor plan. So if you notice, you can look around, we call that LOS, line of sight. They can look around and see who's in what room. They got those visual, the little flags, so they can see if the room's clean, if someone's in there, etc. But they're basically meeting real quick for 5 minutes and going over, hey, here's what we got hopping today. This is what's going on. And oh, by the way, everyone, we're checking everyone's blood sugar today, blah, 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 stuff like that. All right, so what does it look like? So this is San Carlos healthcare system, right? So after 1 year, so I believe this was, it says 2018. So 2017, we started this process. They were meeting 3 or 4 of their GIPRA measures. We started training rigorously. We redesigned the care team. We fixed a lot of the gaps with PRC and scheduling and stuff like that we had no control over, like kind of outside. We got that up and running, and we started getting the help. We started getting those documents back from these people, because what they were doing is they were just, sticking them in piles and scanning them whenever they got to them. We started getting that information back into the system. And in pretty much a 1 year time frame, they went from 3 GIPRA measures to meeting 21 of the GIPRA measures. They improved productivity in their outpatient department, so their visits went up. So they were seeing more patients more efficiently. And then because of that, and because the patients could actually get in, and we also created a fast track clinic that helped ease some of the pressure, they went from like a 50 to 40% no-show rate down to, I think they're at 11% now. But this is a snapshot of 1 year. And then their patient satisfaction scores went up to 97%. So when we look at the IHI AAA, they improved population health, they improved the experience of care, and they increased their productivity, their revenue, and reduced per capita waste, all by doing these changes. So every single healthcare system can do these. It's possible. And we do it, and we do it over and over again around the country. So that's pretty much it. And we can go a little bit more into the weeds, but I really do want to kind of start to open the floor and see if this kind of helped anybody, or if you guys want me to kind of circle back. And then what I can do is kind of show you some live views of how this looks. So what do we want to do first? Do we want to do questions, or do we want to go into a live view in EHR and I can show you how these clicks look? Anyone? Can we just like open up the mics, or what do we do?
Yeah, anyone can unmute themselves. You can put it in the chat, whatever you guys feel like. Maybe if you do a live one, that'll kind of spark some questions maybe.
All right. Yeah, so I'll show you real quick kind of like what a screening bundle looks like and how we can do it. Yep. All right, let's do this. All right, this is the exciting stuff, huh? All right, let's see if I can get in first. See if I have an entryway. And Brian, were you able to get back up, by the way? What is my password?
Yes.
Here, I'll do mine first since I think I have it here.
Brian, you're muted. If you were talking.
All right, here we go. Here's the electronic health record, guys. We're in. We're going to take a live view. Hopefully you guys can see my screen. I already got the first two things picked. So I got a patient, demo patient, and I got the location. So again, that second thing is, what clinic is it? Who is the provider? What time? Where are you? That's the location whenever you hear someone say that, all right? So it's starting out real quick, and it starts out in my notifications page. All right, that's groovy. Let's move along here. See if I can open up. I can open it all the way. There we go. This is a weird EHR. They're all kind of designed different. It's okay. They all have the same bells and whistles. So they have theirs, again, set up in panel view. A lot of you people might have the folder view where it's just a bunch of tabs. I'm working with two sites that have both. So here we go. So a lot of these EHRs work left to right, down, just like we read. So if we kind of just do things left to right, and as you read, top to bottom, you'll kind of hit all the stuff. So what would happen is a patient will come in and present, and you remember I was talking about we're going to want to make sure we have our thing set up. See if this works. It looks like I have a little latency myself. You're going to want to set it up to the clinics. So whoever's clinic you're working. So if I'm an MA and I'm working in Dr. Rauscher's clinic, I'm going to set it up for Dr. Rauscher's schedule. And when I click on that patient's name, it's going to automatically check them in the yellow box. So I see my patient, and now I'm going to go in and room my patient. So I'm going to come in here and I'm going to enter my vitals for the patient, and why are you here? I'm going to look at doing the chief complaint, etc. You guys probably already all know this. So, and then here I kind of move over to the old way of doing things is we used to do manually one by one, put these health factors in, and it was very time consuming, right? And we put these exams in one by one, and it took time. So now I'm going to come along and I'm going to look at the immunizations and see what they're due for and if they're up to date and if I need to give any. So that's where I would look at this one. And then any educations that I gave the patient, I would do here. So remember we were talking about creating those pick lists. We can create these pick lists, and I'll kind of show you real quick what it looks like. So this is something you guys should be writing down, like pick lists, right? So I can come in here, and here I am in a depression pick list. If, let's say I wanted to add anything to here. So I'll kind of show you what that looks like, but I'll just go add. And then what it's going to do is it's going to pull up all of the educations, and I can just add it right to this thing. So you remember earlier I was talking about alcohol brief intervention screenings. So if you have a positive alcohol, so that means the patient drinks at all, you have to come in and do a tobacco quit. So if we're good providers, we said, hey, you shouldn't drink, you shouldn't smoke. So that's what we're going to do. We're going to come in, we're going to look at alcohol and other drugs, or you'll hear them say AOD, right? And it's the third one down. So I'm going to add that brief intervention to this depression screening pick list. So there it is. So now that's on that pick list. So quickly, if I was doing if I'm going in and I'm doing my depression screens, I'm also say, hey man, you shouldn't be drinking either. I'm sure that's not helping your depression. So there we go. So these are managed and manipulated and tweaked, or whatever you want to call it, by your clinical applications coordinator. So if you want to create your own one, by golly, go for it. Go straight to the CAC and say, hey, here's what I need. I do these same educations over and over again. Can you please create a pick list? We'll call it Linda's pick list or whatever, and that way I can grab them real quick. So here's the benefit of them. And this is what I'll show you. Boom, 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 boom. And then I'll just put like 20 minutes. And what it will do is it'll quickly all at once jam those, stuff those out. Or not. Anyways, I don't know why that gave me that issue right there. It looks like I put them in though. Do I got the visit created? Hold on, let me fix this real quick. I'm going to create a new visit so it works better. All right, so we'll do a CD intake for fun. And then I'll make myself the primary care provider. All right. So what it does is rather than going in and out, and selecting each education specifically, that's time consuming, I can do 5 all at once. It will automatically divide the time. So let's see if I can do this again. And so I'm just breaking everything. Oh, it's already got added. Okay, so there it is. So you see it blue. I'll do it better next time. You'll see. All right. So here's that thing I was talking about, activity type. So back in the day, behavioral health didn't really have all these codes that they used to have. So they would literally have to come in here and put like 25 minutes, 45 minutes, an hour. And that's how we would bill out for that. So that was one of the 5 things that you needed to get paid. So now I roomed the patient. I went in, I did an alcohol screen, tobacco screen, domestic violence, all those screens, and I'm annotating those and the health factors. And then as I go down here, I'm going to eventually show you how the quick note works. So now the provider is entering the room. The provider would come up here and see what the chief complaint is. Maybe they would kind of come over here and do a quick review to see what the most recent stuff's going on with this patient. So you can see what are they due for, the clinical reminders. We can see adverse reactions, medications. So they kind of get a feel for, all right, I got a little pulse of what's going on here with this patient. So then they're going to come over here. They're going to start, doing their examination, and they're going to probably add something. Well, they have to add something here to that IPL, the integrated problem list. So like I said, there's multiple ways we can do this. We can go add, which is, we live in the age of Google, so we're kind of search related. So a lot of people just go in here and they quickly type it. Or what we can do is we can create those pick lists like I was talking about. So, when it came around and we started having like COVID and stuff like that, we quickly created these pick lists so we can quickly grab these things. So this was like what we're seeing when this was right in the beginning. So this was before we even had like anything to give them. They were coming in and we were basically had these codes that we could say why they are here. And then, kind of as time went on, we basically started giving the vaccines out. So we created a pick list just for that. So that sped up a lot rather than trying to search through it and look through. Because once ICD-10 came out, there's like a million things and you have to you're reading them all, trying to figure out no, he was not bit by an orca whale. And no, it's so much crazy stuff that we can quickly just grab what we want. So I highly recommend that. All right, but let's go in and I'll just try and pick something. Looks like we have diabetes, cannabis dependency, alcohol. Let's do this aggressive whatever. And I'll kind of show you what this looks like. So we're going to save as a problem. And then I'm going to show you one third cool thing that's a fast tweak that if you guys utilize this, we can actually create these templates that will automatically pump in and they'll create care plans. So this is a huge tweak that later on you guys are probably, we can't go really in depth into it right now, but I'm going to show you what it looks like just a little bit so you kind of say, hey, I want more of that, right? So I'm going to hit this button, use as today's POV. And if you look down here, it gives us this new button. It's called Add Visit Instructions, Care Plans, and Goals. So if I hit that button, I can literally come in here and I can do educations, I can do nutrition and exercise and lifestyle adaptation specific to this purpose of visit and specific to today's visit, right? But also what I can do is if it's something like a wound care or whatever, I can create pre-loaded templates that I would just come up here and I would basically load them and they would put them right in. So all your text would automatically go in here. But thirdly, what this will do for this visit is if you start putting your care plans in here, so let's say like we have a goal is to, I don't even know what I picked, aggressive, whatever. So our visit instruction is to like, go out and check in with behavioral health. Our goal is to not be more, not be so aggressive, do a timeout every time you feel anger, anger management. And our care plan might be, this step, this step, this step, and then come back and follow up every 2 weeks. You come back and have another session. And then what this will do is pull into the note, and it will also show you step by step. So, oh yeah, last week we spoke about this, and this week, and it'll just keep growing in that note. It'll pull in all the old stuff. So this is a very underutilized thing in Indian country. I don't even know if any of you have even seen this before. It looks like we have a raised hand. Ms. Harris, you want to?
Yeah, I had a question. So one of the things that we have discussed with some of our partners is trying to streamline the note process that providers are inputting to make sure that they're all kind of like capturing the same thing. Would the template feature on here that automatically populates into those sections be a good place to kind of like do that they could just, it'll populate in there and then they can make sure that they're leaving a note based off of that? Yeah,
totally. Yeah. And these work really well with things that are like repetitive. Like, so let's say sports physical, right? It's going to be the same thing over and over again. It doesn't have this, doesn't have that. If they're fine, blah, 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 they can play sports. That's where you just hit these templates and it automatically just stuffs it for you and you're done. Super easy, right? Wound care probably has a lot of the same stuff. So you could do, change dressing every hour. If it looks infected, please call, take antibiotics, blah, blah, blah. It's basically canned stuff that can go in there that's like pre-scripted that they just hit the button and it's over with. All right. So moving along, so that's the IPL, and this is a major room. There a lot of tribes are starting to work on this to get this dialed in and get it better. And so I would say start taking a look at that. All right, so moving along, we're going down. I would look at the medications, do medication reconciliation. If I'd keep coming down, and then this is the second set of eyes. So this is allowing the provider now, if they want to add an education or add an exam, they can do it right here. Then we come over to notes. So let's rewind a little bit. So we did the first way when the MA went in and they manually put in all these screens, right? Now I'm going to rewind. We didn't do any of that stuff. I'm over here, maybe in health factors or whatever, or maybe I'm even on the triage thing. So I'm getting done doing my vitals. I'm the MA, and the patient has this form, and they basically said, I drink or I smoke or I don't, or I feel safe in my home or whatever, right? I don't feel depressed. So now what they're going to do is they're going to input that. So notice that I'm in the triage tab, and I want to show you the speed of how this works. I can come over here to quick notes. I could hit the screening bundle, and it will automatically jump me to notes. It will automatically select the correct note title, and it will automatically pull up the dialogue for me. So in one click, I got right into the woods. So now I'm going to put this more front and center so we can see it. And then I'm going to demonstrate how this pushes outward, right? So I'll start with the tobacco use screen. We'll have some fun with this. We'll do the tobacco use. And let me open it up a little bit. Sorry, it's got this like latency thing. So I think I got it, but I don't got it. Because this is like, I'm remoting to you guys, and then remoting to Montana and remoting from Arizona. So we're all over the world now in this new post-COVID world. All right, so we're gonna go in and we're gonna say the patient has never smoked or used tobacco, the current former smoker. So I kind of picked that one. And I keep it easy. I just say they smoke every day. And what I did in this reminder dialogue is I put right at the top, the one I need to hit, tobacco quit. So boom, right at the top. Then the next thing I did was you could default a lot of these things. So I just default a lot of these, like this site I haven't got to, but I defaulted the good, but I also will just default the education to 2 minutes. So they don't even have to click it. So that one click would be good enough. And I talked to Chris Labor about this too. He says right now they don't even look at this stuff anymore. They're really looking at, did you provide education? Because what they were doing is people would just mention it and then they put 2 or 3 minutes down. We used to have that, but not so much anymore. All right, so I went in, I just did the education. I said they're good. There's no asterisk next to this, but I'll go ahead and say 2 minutes. So if you look down here at the bottom at the boilerplate, you're going to see that this is the information it's collecting. All right, next up, activity screen. So what I like about these dialogues is we can kind of like script it too. So you're like, active, what is active? What is not? Well, it tells you right here. 5 hours a week or this many minutes or blah, blah, blah. This is what an active person, a very active. So I'm going to go ahead and say active. So I'm entering that. This patient is active. And if I wanted to do an education, I could actually provide some education. And I'm going to say, like, keep it up, buddy. Keep walking those 6 miles a day. It's really working. All right. I'm going to come down here and do the alcohol screen. So a lot of sites use Cage. I'm pretty sure you guys probably use Cage. Some use Craft, some use, but here it is. And basically, most people will hit like one of these. Wait, hold on, let me get this wider. Forget it. All right, so that's one. So that would be a Cage 1, right? So we're gonna go ahead and do that. So remember, the 2 things that require secondary action is a positive tobacco to positive alcohol. So we already did that. And then what a lot of people were thinking is like, oh, this thing called ESPR came out and I have to do an ESPR. They thought that by hitting this brief interview, they were getting the credit for it. They weren't. You have to have, like, Brian probably knows this like the back of his hand, but you have to have like some kind of behavioral health meeting within so many days or something. So what we figured out is that just informing them of these services was enough. The education itself would satisfy that ESPR. So what we did is we started putting that at the top, and you see how we defaulted it. So we're telling the patient that they have a positive screen and that we have services available and they can partake in these services whenever they want. Automatically defaulting. We're going to do a depression screen. And a lot of sites, so some of these, what I've done is I've created the depression screen to do a PHQ-2, and if they have a higher than, if it's a positive, it will automatically open up the PHQ-9. It's kind of a little bit of a pain in the butt, but I can help you guys do it if you guys want to do it. So I'll give this person a score of 1. So we're just coming along. I'm unable to click on this button down here. So there we go. And I think I'm getting locked out. There it goes. There it goes. And for fun, I'm just going to try and finish this now. And if you're missing something, like, it'll stop you and you have to go back. Oh, I forgot to add the time, or I forgot to add this. So this is automatically, without me typing a word, stuffing this into my note. But the benefit of this is it's also pushing this information onto here. So if you look over here, I never clicked one add button here to add these. It automatically stuffed that in there for me and is giving me the credit. So boom, 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 real quick. We get the GIPR credits that we need to get. We improve our measures, rah, rah, rah. So, and if you come over here to the educations, without me going in, it put all those educations in there. So way faster. And if you remember, I was here. I was like, I think I was in triage actually. And all I did was come up here, hit that quick notes, hit that button right there, and it automatically bounces me in and gives me that template and gives me that note title. So we want to start thinking in healthcare, how can we make one-stop shopping, one click, like Amazon style? How can we do this one-stop shopping, one-click shopping in our EHRs? This speeds up your processes. And we all know a lot of what we do, that's the biggest thing. We're in this constant fight with time. And that's how that works. Secondly, the one thing we didn't really talk about were the reminders. So if you come down here, once you have a note where you can just free text in, on the bottom left, you have reminders. So again, these are chart reviewing for you. So they're telling you, hey, this is a diabetic who needs the eye exam. This is the diabetic who needs the foot exam. So if I click on that, again, these function the same way as that screening dialogue. What these will do is when I click these, it will push that information out and we'll get these credits. And the next time you log in, that diabetic foot exam will not be red, it will be blue. So these are the things that we can optimize. These are high leverage points. So the EHR, high leverage point, we could get a lot of change out of it just by manipulating it. And your care teams, who does what, who looking at all the stuff you have to do, roles and responsibilities. So these are the two biggest things that I work in improving healthcare and improving our measures. All right, that's pretty much that. If you guys want, I mean, I can try and show you how to do like a super bill pick list. I kind of show you historical services. That's another huge one that we mess with. Let me see if I can even find it in this person's EHR. I don't even know where it is. Looks like it's right here. So do you see this button? So we have a lot of things I like to call asks, right? And we can get credit for this. So we can ask people, we have this nationwide drive called Know Your Status. So we can ask them, hey, do you know your status? Yeah, I had an HIV test when I started working for the DMV, or I had an HIV test when I joined the Army. Or are you gonna know that date? Probably not. So just guesstimate, like, okay, the guy says he had one in 1994 when he joined the Army. So we can go in and we can add these and we'll actually satisfy that GIPR result. We can also ask about a colonoscopy. We can ask about a PAP. We can ask about all these stuff. And we can enter this information historically. So what I'll do is I'll add an historical DMI. So they had a diabetic eye exam at, they have an eye doctor in town and they've gotten the retinopathy and they're like, no, I'm good. I've had this, I'm wearing glasses right now. And here's a little hack. You guys just hit this other button and then you can just put here, patient reports, negative, etc. And then you save it, and that will satisfy that DMI. So if I go back into those clinical reminders, that diabetic eye one will eventually, if I log out, log back in, it will go away. So I won't need it anymore. So these historical services, by the way, are, we manipulate them. We can add to them. So for example, I don't know if you were with me, Brian. No, you were not. I was up at the Sioux in Northern Michigan. So different group of people, right? And I was up at Sault Ste. Marie, and the doctor's like, hey, can you add hip replacement to this? I'm like, yeah, that's a good, if a person's had a hip replacement, yeah, that's a good idea. We want to add a hip, we want to annotate that. So we did. And I'll kind of show you how we do that. Just so once you guys see the light, you know these things are possible, then you can go back and harass your CACs to do all this hard work. So I'm basically creating work for a bunch of CACs right now. So they're gonna love me. All right, so here's the pick list, right? So this is the behavioral health one. I can pick different pick lists in here. And you know what? The one we were looking at called historical services, in the back end, it's called GIPRA. There it is. So all those things that are in your historical services, if you want to add to it and put like a Hep C or chlamydia or any of these things, they can literally just go in and add it right here. So there's the colonoscopy, we just did the diabetic eye, all that stuff is in here. So I can add more codes to that. And then if I add a code, it will then show up as selectable right here. So again, weird things like hip, hysterectomies, hip replacements, stuff like that. If we annotate them in here, then it actually affects some of these clinical reminders. So if you've had a hysterectomy, that PAP reminder is not going to go off for you anymore. That reminder is going to be looking through and it's going to say, oh, I found a hysterectomy over here. This no longer applies to this person. So there's those. So as you can see, we can manipulate these things. We can add to here, to these things. So that being said, I am about out of gas verbally. So I can't really talk much more, so I really want to hand it over to you guys to start asking questions and talking and stuff like that. And I will stop sharing my screen. All right, I hope this stuff was informative to you guys. I hope you learned stuff. I hope you have questions, and I hope you guys want to dig in and you're curious and you want to know more. And feel free to talk. Open questions. Is there anything?
I heard you mention the different assessments that you guys conduct, and I was curious about the domestic violence assessment. What does that look like?
The domestic violence one?
Yes.
Well, it depends on where you're at. There's different ones, but let me, maybe I'll share my screen and I'll take a look again. Let's see which one they're doing, by the way. And I can just log into another tribe if not. So when I go into my quick note and I pull up this, and they have different ones because they have like sensitivity ratings. So like the weird one, like, do you feel safe in your home? Sometimes you have, sometimes what happens with that weird question is like, if you're like the at-home person and they say, do you feel safe in your home? That's kind of a representation of what you're doing as, you know, a stay-at-home mom or a stay-at-home dad. So you're not gonna, but if you ask the question, have you ever been kicked, you know, had your hair pulled or spit on or punched in like the last month? That's something that happens to you, and it will actually change the results of the questions. So you might get a positive out of this one, but a negative out of this one. But we'll take a look at what they have in here. And it looks like they have no scripting. So it is basically, my idea is that this is just, do you feel safe in your home? Is what they're asking the patient. But like I said, we can manipulate these and we can put anything we want. So this is when you work collaboratively as a team. You sit down in like an improving patient care or an EHR meeting, and you say, hey guys, I don't really like, I don't know what I'm asking here. Can we script it and put something in there that I asked them? And we can say, yeah, let's do it. Let's put it in there. What do you want to ask them? And they can say something like, you know, has this, or this ever happened to you in the last 2 months or 6 months? And then we can. So right now, I guarantee you, they're just saying, do you feel safe in your home? And they're just putting whatever the result is right there.
There's more open-ended questions.
I have a question.
Yeah.
Actually, I have an answer. What we ask here on the reservation is, have you been a victim of domestic violence, past or present? And usually they will say, yeah, years and years and years ago. And so we just document if it was years and years ago as a child, or if it was previous, you know, or if it was present. Like if they feel, you know, now they're being a victim, we would document that as well.
Awesome. Yeah. Yeah, I like it. I do like the ones that, like I said, it's tricky how you finesse these questions because, like I said, you know, do you feel safe in your home? Well, if you're the homemaker, you're like, what are you talking about my home for? Yeah, of course I do. It's my home. But you might actually have domestic violence happening. So it is really important that we script these well and we think about the patient's sensitivity and how we want them to respond. All right. And I don't know what you guys do for alcohol screens. Like most of the places I go, it's the cage because it's more of the reason why they use the cage a lot is because it's more of a thing that reaches a little bit more down the line of, is this person behaviorally ready to make a change? So they kind of like to ask that cage, like, do I feel the need to quit? Have I ever had an eye opener? Things like that. You know, that's kind of more like, hey man, we're getting there. We might want to change. So they kind of ask that in a lot of places. Whereas the other ones, you know, do you drink? How much do you drink? Sometimes doesn't really indicate behaviorally whether they're ready to change or not. All right, any other questions? Did anyone learn anything? Did you guys already know all this? You guys are already geniuses? Or did I turn on any light bulbs for anyone? Put it in the chat if you can. And does anyone want more of this? because I like live for this junk. So I can like totally love this stuff. So if you want more of it and you want to know how to like make templates and make dialogues, just let me know. All right.
Yeah, and if you don't want to share on here, please feel free to share on the survey. The link is in the chat.
Yes, like Odi said, links in the chat. That's also where you can get the continuing education. And if there's no more questions, James, thank you so much. And we'll see you again on the 28th.
Awesome. Thanks a lot, guys.
Awesome.
Always,
Thanks, guys.
always fun hanging out with you. All right,
Bye,
bye.
guys.
Yeah.